Hello, this is Ann Kelly. I'm here at the University of Kentucky College of Public Health at the National Coordinating Center for Public Health Services and Systems Research. Today we have the first in a series of 10 webinars that are grantees who are recipients of our 2013 Pre- and Postdoctoral Researcher Awards. And Chris Maylahn is teed up today to present the first in this series. So I'd like to welcome you all. I think we'll have some more people joining as we go through the introductions, but we're going to go ahead and get started. I know Chris has a terrific presentation planned, and we have commentary by two of his advisors as well. So as I said, I'm here at the Coordinating Center. We have the responsibility and are funded by the Robert Wood Johnson Foundation to manage a number of grants in public health services and systems research, and this series are those who received small early career awards for pre- and postdoctoral scholars. Today's first presenter is Chris Maylahn. Christopher Maylahn is an epidemiologist with the Office of Public Health Practice in the New York State Department of Health. His principal focus there is on the state's health improvement plan, which is entitled The Prevention Agenda Toward the Healthiest State. He's also a member of the New York Public Health Practice-Based Research Network and has served in numerous administrative and leadership roles and has been responsible for many program initiatives in the public health arena, including cardiovascular disease, diabetes, asthma, obesity, age-related eye diseases, and epilepsy. So he has a long career. Chris, are you there?
I am.
Good morning.
Good morning.
In addition, when Chris will be presenting for about 20 or 25 minutes, and then we've invited two of his advisors to provide commentary after he completes his presentation. Dr. Ross Brownson is on the line, and he is an expert in chronic disease prevention and in applied epidemiology. Dr. Brownson co-directs the Prevention Research Center in St. Louis, which is CDC funded and jointly led by the Washington University in St. Louis and St. Louis University. He's also an expert in the field of evidence-based public health. He currently serves as a member of the Faculty Advisory Council of WashU's Institute for Public Health and a joint appointment in the University School of Medicine. He's also associate editor of the Annual Review of Public Health and on the editorial board of 5 other journals and has authored numerous textbooks. So we're very honored to have Dr. Brownson with us today. Ross, are you there?
I am here. Good morning.
Wonderful. Thank you. And then our second commentary and third presenter will be Dr. James Crissetti, who is the commissioner of the Albany County Department of Health and has served in that role since 1992. He's also a clinical associate professor in health policy at the State University at Albany School of Public Health. He's a board-certified physician in the specialty of public health and general preventive medicine, received his medical degree from George Washington University, postgraduate training at Johns Hopkins, where he also received a master's in public health. He's a Navy veteran, served at Bethesda Naval, and we thank you for that service. He's also a former member of the National Health Service Corps. Dr. Crissetti, welcome, and can you hear me?
Yes, I can, Ann. Thank you. Pleased to
be
a
welcome.
participant.
Great,
Thank you.
Great. So I think we're ready to go. When we finish with the formal presentations, we'll have a period of Q&A for as long, and then I'll give you a little wrap-up at the end of our upcoming list of presentations. And with that, I'll turn it over to Chris.
Thank you, Ann, and welcome for those of you on the East Coast. Good afternoon. It's a pleasure to be spending this time with you today. I'm going to advance through a couple of slides that repeat what Ann had put up and draw your attention to the New York Public Health Practice-Based Research Network. The Junior Investigator Award that I'm going to be describing to you is part of the portfolio of work that our network has been doing since 2000, when we first received Robert Wood Johnson Foundation funding. Our primary academic partner is the State University of New York at Albany School of Public Health. You can see from this slide that the network has 6 other partners, which have each contributed in some way to the research studies we are doing. Let me point out that local health departments and the association that represents them are 2 of our key partners. So the Junior Investigator Award that's supporting me as a doctoral student has a dissertation committee, and the members of that committee are shown on the next slide. Dr. Benjamin Shaw is the chair of the Department of Health Policy Management and Behavior in the school. The other committee members include Dr. Guthrie Burkhead, who serves as the Deputy Commissioner of Public Health at our State Health Department, and Dr. Crescetti, both of whom, as Ann pointed out, have faculty appointments at the school. Dr. Brownson, who is well known to this audience, chairs the Department of Epidemiology at Washington University and St. Louis School of Public Health, serves on the committee, and is my mentor on the Junior Investigator Award. And I've had the great pleasure to know Ross since the early 1990s and work with him on a number of projects which he's taken such a leadership role in accomplishing. So here is a brief outline of what I'd like to talk about today, giving you a brief background on the topic, the research question, and then the 3 phases of the research that are underway. So with those introductions and that background, let me begin. The topic, collaborations between local health departments and hospitals, is getting a lot of attention now that the Affordable Care Act requires nonprofit hospitals to work with local health departments. And the new Public Health Accreditation Board standards recommend that health departments partner with hospitals for the very same purpose. Very new, very exciting, and ripe for scrutiny. Just because the IRS requires that hospitals collaborate with public health as a community benefit, and FAB believes collaboration is a prerequisite for public health accreditation, doesn't guarantee it will happen or that it will last. That is where sustainability comes in. Actually, it was Ross who got me interested in the topic of sustainability. Several years ago, he convened a national meeting on sustainability research and invited me to attend the meeting to provide a, quote, public health perspective to this emerging field. At the conclusion of the conference, I was determined to test out the concepts I had just learned about. I soon had an opportunity, which you will hear about next. My presentation is outlined here. I will provide a brief background for the study, describe the research question, and then review the status of each phase. So what is a natural experiment? I'm sure there's a literature on this, but I like the Wikipedia version. A naturally occurring instance of observable phenomenon which approximates or duplicates the properties of a controlled experiment. So what are those circumstances and how are they affecting New York State? Well, it began in 2008, 6 years ago, when the New York Department of Health launched the Prevention Agenda Toward the Healthiest State, which was then the state's health improvement plan to address 10 major priorities affecting the health of New York residents. The prevention agenda was the brainchild of Dr. Richard Daines, who had been the CEO of St. Luke's Roosevelt Hospital in New York City before becoming Commissioner of Health. Ahead of his time, Dr. Daines called on local health departments, healthcare providers, health plans, schools, employers, and businesses to collaborate at the community level to improve the health status of New Yorkers through an increased emphasis on prevention. Nonprofit hospitals and local health departments were called upon, some would say strongly encouraged, to collaborate with community partners to conduct community health needs assessments, select 2 or 3 health priorities to focus on, and identify opportunities for action that the local health departments and hospitals could pursue, either individually or in partnership, to alleviate the priority health problems that the communities had defined. Hospitals submitted to the department their community service plans, and local health departments submitted their community health assessments that each included opportunities for action. Just a little background. In New York State, the public health law and the accompanying regulations have required that local health departments conduct a community health assessment every 4 years, and that hospitals must produce a community service plan every 3 years. I'm not sure how unique this is, but it's certainly been a big factor in public health in New York State. In 2012, the department issued new guidance that began requiring local health departments and hospitals to complete a collaborative community health assessment and planning process that includes other healthcare providers, other organizations that represent various sectors in the community. They must submit reports documenting their progress. The 2012 guidance also explicitly required that local health departments complete a community health assessment and a community health improvement plan, which had not been required in 2008. The new requirement for a community health improvement plan was consistent with the recent Public Health Accreditation Board recommendations for local health department accreditation, which specify that they, quote, either conduct or participate in a collaborative process for completing a comprehensive community health assessment, end quote. In addition, local health departments must conduct a comprehensive planning process resulting in, again, quote, a community health improvement plan, develop healthcare service capacity, identify and implement strategies to improve access to healthcare, and use a performance management system to monitor achievement of objectives, end quote. The language in New York's guidance for community health planning in 2012 was comparable to the new IRS requirements established under the Affordable Care Act. The IRS requirements state that hospitals must, quote, consult with members of their communities and take into account input from persons who represent the broad interests of the community served by the hospital facility, including those with special knowledge of or expertise in public health. Every 3 years, hospitals must, quote, conduct community health needs assessments in conjunction with local health departments and others, and develop an implementation strategy to meet the needs identified through their assessment, as well as a set of performance measures to track progress. So you might wonder, with the Affordable Care Act, why does New York state policy even matter now? Well, perhaps not for hospitals, but the department is also promoting the FAB recommendations to local health departments, which will push local health departments to be more proactive and hopefully hospitals to be more engaged. So that sets the bounds of the natural experiment. So what came next? So the research question that I posed for the project, given my interest in sustainability, I decided to focus on the possible determinants of sustainable collaborations in New York. The communities where the collaborations were formed and now operate provide a unique opportunity for practice-based research about their structure, their organization, service delivery, and outcomes. 5 years have elapsed since they started. So the objective of this research is to answer this question: what organizational and structural characteristics of a hospital local health department collaboration are associated with collective impact? You've heard that term more and more recently, and the collaboration's capacity for sustainability. In addition, answers to 2 questions in the Public Health Services and Systems Research Agenda will be addressed. I'm not going to go through those, but those include question 10 and question 11 of that agenda. So the first phase of my research and a requirement of the Robert Wood Johnson Foundation was to complete a literature review. Not an easy task given the greatly expanding knowledge and articles published in this topic. So I looked at articles describing the following sort of 4 domains: organizational and structural factors associated with community collaborations, examples of recent collaborations that have been implemented across the country, typologies and functions of collaborations, which in the literature are also called partnerships and coalitions, which made it a little bit more complicated, but certainly expanded the number of articles that I could look at. And then fourthly, the sustainability of these collaborations as a nascent field of interest. Now, there have been some studies in the literature about hospital public health collaborations, but they're mostly in the gray literature. None have investigated the long-term sustainability of these kinds of collaborations either. I also contacted a sample of key informants to learn more about actual collaborations and other developments in this area. I spoke, for example, with researchers and positional leaders across the country, including Paul Jarris, Sharon Moffitt, and Monica Valdez-Lupi at ASTHO, Dr. Joe Ivy Buford at the Academy of Medicine, who also chairs our New York's advisory group to the prevention agenda, people at the Hilltop Institute in Baltimore, Kevin Barnett in California, and others. I learned about work going on in North Carolina and Florida, and through this sort of snowball sampling, discovered more and more that quite a bit was going on across the country. My sense from these conversations, though, is that New York was on the right track and a bit ahead of the curve. This slide summarizes what I learned about community health partnerships, which tends to be the term used more often in collaboration, so I've used it here. The work of Roussos and Fawcett, Mays and Scutchfield, Wolf, Butterfoss, and many others helped me construct this view of partnerships. The next slide summarizes what has been shown to be the key determinants of successful partnerships. Taken from a variety of studies, these factors may seem familiar to you or intuitively appealing and not at all easily changed. I've used this list in forming what I will study in New York. Finally, I looked at the literature on sustainability and found surprisingly little has been published, at least in terms of sustainability of collaborations, and specifically collaborations between hospitals and public health. In fact, the field is so new that an agenda for research about sustainability of public health programs was published just 3 years ago. Those of you who attended the recent Keeneland conference, who may have attended the session on dissemination and translation that used one of Deering's papers, will recognize him. The second phase of the project was to describe the current status of the collaborations in New York. What is actually going on in our state and the communities across the state? Mindful of the themes that have emerged from literature review, I was interested in particularly to assess organizational structural factors in the collaborations and whether I could find any relationships between these factors and two desired inputs of the collaborations. You will recognize these from the Affordable Care Act and FAB. One was conducting a collaborative community health assessment, and the second was developing a health improvement plan. So the practice research team I assembled for this phase is shown here. Sylvia Pirani, who's listed under New York State Department of Health, directs the Office of Public Health Practice, and my colleague Priti Irani was also a key contributor to this phase. At SUNY, I was able to get engaged Dr. Shaw and 3 students at various levels of their education, Caroline, Temi, and Eniola, who are listed here. The data sources that I use to assess these determinants are shown here. The first is the NACHO profile series that utilizes a series of core questions and modules, many of which are relevant to my study. I mention this source first because the study is conducted in every state in the country on a regular basis and offers a good opportunity for states to look at their own local health departments and make comparisons with the national profile. The second source is unique to New York and provided me with some data on very relevant indicators. Community health assessments and community health improvement plans developed by local health departments and community service plans by nonprofit hospitals were submitted in November 2013. Some results from these reports were summarized in the recent presentation I made at the Keeneland conference, and they begin to illustrate where the collaborations are after these first 5 years. So here is in summary the method I used for this phase of the study. It's a retrospective cohort study, 58 local health departments, and every one of them submitted a report, and 148 nonprofit hospitals, many of them in New York City. And I looked at 3 measures: whether they completed a community health assessment, whether they developed a community health improvement plan, and what is their plan for sustaining community engagement. While the analysis is still underway in both of these data sets, I wanted to use this particular slide to wrap up what I've actually learned about these collaborations. If you go down the list, you can see, first of all, what the local health departments reported and what the hospitals reported. So fewer than 40% of the collaborations are actually using evidence-based interventions for both of the priorities that they've selected. just about the same percentage and number provided process and outcome objectives in their plans, slightly fewer for hospitals than for health departments. Looking at the objectives that they described, here we had about 2/3 submitted what we call SMART objectives, find at the bottom of the slide. Again, higher for local health departments than hospitals. The plans that they developed were posted online in about half of the health departments and about 3/4 of the hospitals. And then finally, and particularly relevant to this study, is whether they described a plan for sustaining community engagement. Here the numbers were quite low, with 28% of the health department's plan and only 21% of the hospitals having such a plan. Here is a very rough picture of the number of partners working with each collaboration in 2013. The numbers range from 2 to 14, averaging about 6. That's not bad. What we did find from the reports is that the number of partners engaged in the collaboration increased when they went from planning to implementation. And that's exactly what we hope to see. Looking at the NACCHO profile series next, here is a brief summary of what is in the survey. We looked at survey data from 3 years that spanned the period of time of the study, 08, 2010, and 2013. Core questionnaire in the NACCHO survey gets at the 6 topics listed under the core. They were each asked all 3 years of the survey. Then the survey uses modules, and the modules were more intermittent. They had a module on partnership and collaboration that was asked in 08 and 2013. Then there was a community health assessment and health improvement planning module that was asked in 2008 and then became part of the core questionnaire in 2010 and 2013. So just to summarize what these 2 data sets have revealed for me, again, the percent of plans coming in from the health departments and hospitals containing the recommended elements range from below 25% to just about 3/4 of the plans. The number of partners reported varied considerably. The plan for sustaining engagement of partners was described in about 21 to 28% of the plans. Looking at the NACCHO data, fewer than half of the health departments were collaborating with hospitals in 2013. This is at the national level. I think it's fair to say in New York that number comes close to 100% based on the reports that we've gotten so far. And then in 2013, and this reveals something about one of the factors, which is leadership, that the completion of a community health assessment was significantly greater in local health departments when the top executive had a master's or doctoral degree. So now I'm going to move into the final phase of this project, and I have to credit Ross Brownson for his leadership and guidance in recommending this particular phase as the way to measure sustainability, which we don't have in a cross-section of New York collaborations, or really in any of the collaborations other than what they reported on their instrument. My plan is to conduct a case study in 4 counties to gain insights about the factors related to collaboration and sustainability and build off the literature review, which you've already heard. And then the key here is to use a tool developed by Doug Luke, who's one of Ross's colleagues out at Washington University. This tool was supported by the Office of Smoking and Health at CDC and has been widely used by Dr. Luke across the country. In fact, members of our chronic disease division use the tool to look at some of the programs within that division. So with four counties being targeted, I really have two options for selecting those counties to study. The first option is listed here. This is the option that Ross had suggested, picking two counties that show a high capacity for sustainability and two with low capacity for sustainability. A second option that was offered by Dr. Scutchfield and Preibel from their work on the model of collaboration study was to pick four that have excellent structures in place in a diverse partnership and are broadly representative of our counties in New York State. Both options have their pros and cons, and I'll be using my dissertation committee to decide which option to pick. The kinds of questions that would be asked in these focus groups with the four counties, examples are shown here. What makes a collaboration distinct from a program? And what are the factors that contribute to its success and keep it going, or that get in the way? So the two-step process that I'll be using to adapt the tool in New York State are listed here. In the first step, I will conduct focus groups to solicit input about measuring sustainability, pilot the instrument in four counties, assess it for acceptability and internal reliability, which Dr. Luke has kind of guided me on. It's time-consuming, it's laborious, but it's really the process that I need to go through to adapt his tool. The second step would include taking the feedback from the pilot test to make further modifications, test the adapted tool again, and presumably implement it in New York State on a larger scale. At the very least, I would prepare a journal article and explore other avenues of dissemination, which the Robert Wood Johnson Foundation has been strongly encouraging us to do. So that gives you a very brief and broad overview of the three phases of the study. I want to thank you for listening. I will entertain a few questions if you have them right now. Then I'd like to turn it over to Ross Brownson.
Chris, I don't see any questions in the chat box, so unless someone speaks up right now, we'll go ahead with the commentary.
Okay,
Very
good. So I'm going to invite Ross to provide a researcher perspective on what I've just described. Please go ahead, Ross.
Okay, good. So thanks, Chris. That was really great. And as you can see, the sort of scope of what Chris has taken on is risky. The sort of scope creep on the tension of doing something that is so important and so broad, but also pragmatically getting him finished with his doctorate in, before the next millennium turns over. So we're always struggling with that tension, but you can see that he's got some really great ideas and some plans there with the work in New York. I'll just make a few comments and also probably raise a few more questions for the larger group, and those of you who are maybe entering the PHSSR field or thinking about some of these areas in your own work, reading what Chris presented as well as a few other ideas might give you some things to work on in your own state and local areas. Obviously, this is a really hot topic. When New York started this, there wasn't health reform at the scale that there is now with the Affordable Care Act. So it's grown even hotter in terms of this linkage between public health and the hospital systems and other healthcare systems. I think also this is a really great example of where PBRNs and sort of the first generation of PBRNs that focused more on clinical practice, and now the newer rounds which focus obviously on public health practice, and how those worlds can kind of work together and facilitate this kind of work that is really where all the money is kept. The systems that public health is a tiny drop in the bucket of the total funding out there, and so this allows that more common linkage, and in many ways probably people finding out what public health is when they think of health more as medical care than prevention, primary, secondary prevention. This area of sustainability, in another world, I work a lot in this area of dissemination and implementation research, the idea of translating research to practice, and this topic that Chris has taken on is one of the least understood and most important areas in D&I research as well. So it's a really great ability to fill the void here. I think some of the other questions that we've struggled with in thinking about this is, Chris mentioned in one of his slides the idea of impact. You know, what is impact for this area? Is it actually a stronger collaboration? Is it a collaboration that is sustained? Is it quality of healthcare? Is it quality of public health services and sort of following essential services or the public health accreditation standards? And it's probably likely that what impact or quality is may differ from the lens of a local health department leader compared with a hospital leader. And so I think part of what Chris is going to learn here is what that difference really looks like and how the lens of where someone sits might influence that. We're doing some sort of parallel work, not so much on sustainability, but just looking at some basic collaborative issues between state public health leaders and healthcare systems. And we found most report some kind of collaboration, and it varies a lot by program area, you know, tobacco compared to cancer screening. And it's also often that the collaboration fits a lot more around sort of client-based, individual-based services as opposed to system-wide or policy change. And I think that's an area that is really important because, as we all know, most of the impact in public health practice comes through broad system and policy environmental changes. And so I think that's another area that will be perhaps not a prominent part of Chris's study, but something for the next generation. I guess the last little bit is just to think about this as early, or maybe not first generation research of what Chris is doing, but certainly early generation research on sustainability that takes advantage of this natural experiment that's happened and happening in New York, and just encouraging you to think in your own work about, are there opportunities like this where you could look at a state level or at a local level or even within a community at sort of ideal systems. And I think in many ways this combined case study, quantitative, qualitative approach is the best way to approach this. So I think I'll leave it there, and we want to make sure we have plenty of time for questions. So I'll turn it back over to you.
Thank you, Ross. I'm going to next introduce Dr. Crescetti. Dr. Crescetti is the director of the Albany County Health Department. It's one of the larger counties in the state. It has a mixed urban and rural area. Dr. Crescetti is one of the leaders within our local health department infrastructure, and I'm very pleased to be able to work with him on this dissertation, but also to have him offer his perspective from a practitioner.
Well, thank you, Chris, and good afternoon, everyone. Greetings from Albany County. Very pleased to be a participant in this webinar, and I appreciate the opportunity to comment from the practitioner perspective. First, let me give thanks and kudos to Chris for his presentation and the proposal to research factors that lead to successful and sustainable collaborations. Well done, Chris. As a local health official, I can't emphasize enough how important this work is to local public health practice. I was reminded of the Institute of Medicine's 1988 landmark report, The Future of Public Health, that defined the mission of public health as the fulfillment of society's interest in assuring conditions exist in which people can be healthy, something we refer to frequently in our practice of local public health when talking with community partners. And those on this call, I'm sure, know the substance of public health being defined in that report as organized community efforts aimed at the prevention of disease and promotion of health. Well, we can't fulfill the vision of public health, that is healthy people and healthy communities, without strong partnerships and collaborations that'll help us accomplish the 3 Ps of public health: prevention, promotion, and protection. So I'm really excited about this research and how it might inform local public health practitioners and help us to understand better ways that organizational and structural factors of local health departments and hospital collaborations can influence impact on community health in our communities. And to kind of piggyback on what Dr. Brownson said, how are we measuring impact as a local health official? I would hope that we would be able to look at successful collaborations as leading to an improvement in some community health outcome measures, but it's, I think, an important part of Chris's research. So just a brief comment as we look at successful collaborations and sustainability. We know there are these organizational and structural characteristics that I look forward to learning more about as Chris goes through phase 3 of his proposal. I'd also be interested in knowing some of the other factors that we hear about frequently at the local level when we're working with community partners. Things that are simple, like communication and building trust, getting along with one another, and the factors that also influence the formation of partnerships. As Chris pointed out, in New York State, we have the prevention agenda and a rather soft requirement in 2008 that health departments and hospitals work together, and then a harder requirement. I guess it was, I may say hard, it was a requirement in 2012. So people can be forced to the table to collaborate because it's a requirement, but it's really important to know what can keep that collaboration going forward in the future, and I think Chris's research will help us to understand that a little bit better. So I think I'll end my comments here and just open it up for questions and answers. Thank you.
Okay,
thank you both. Go ahead, Ann.
Chris, did you want to wrap up with any other comments before we start with the questions?
No, not really. It's very very relevant to have your comments, Dr. Fischetti, from the local health department perspective for two reasons. One is, our practice-based research network is set up principally to focus on local public health practice and to understand how to improve public health practice, how to influence the outcomes of local health departments. That's what our office here in the health department, the Office of Public Health Practice, is about. So I picked a topic to look at that was not just a interesting research topic, but that would hopefully be very practical, as you've just pointed out. But I'm well aware that will not be easy, and just the very fact that 21 to 29% of our collaborations had a plan for sustainability makes me believe that this is going to be a tough road ahead for many of these collaborations. So hopefully I can learn something, share with our communities, share with people like you, Dr. Fischetti, and hopefully see some progress as we move forward.
Chris, this is Ann. My first question, as a policy change, how does New York State enforce this planning requirement for hospitals, and what are the sanctions if they don't comply?
Well, we got a community health assessment and a community health service plan from every health department in the state and every hospital. We had 100% compliance to that requirement in 2013. That's pretty good. I'm not sure exactly what action would be taken. I think we would use most likely a soft sell approach to encourage. And believe me, not every plan was of equal quality. So we had real variation, and we've summarized what we learned in those plans, and we've given what we believe to be constructive feedback to the hospitals and health departments. Presumably that sort of carrot and stick approach might be better than any kind of penalty. If in fact we can provide the kind of feedback that's going to help them along, then perhaps they're more likely to respond. But our office does recognize we have that requirement, and we will be looking at that process in the years ahead to figure out the best way to approach it if we do find we have low compliance going forward.
Okay, thanks. Our first question in the chat box comes from Sean Haley, who asks, have you given any thought to assessing the relationship between sustainability and population health outcomes?
Sean, I'd be happy to answer that question. Sean is here in New York, and it appears to be very interested in the work that we're doing in a number of ways. Well, first of all, sustainability is a distal outcome, but population health outcomes are even farther down the line. But that doesn't mean they're going to be ignored. And we actually have a system in place for our prevention agenda in which we've identified tracking indicators for every single priority that we've developed. We can track those indicators using data that the State Health Department has, and in fact have made into a state and county level dashboard so that anybody in a community can see where they lie in relationship to these population health outcomes that have been developed through a consensus process. So we actually have a system in place to track those outcomes in the future. Now, I'm not naive, and I do believe that some of those changes are going to take a while to occur. But we've actually, in the process of developing the current version of the prevention agenda, which covers the period 2013 to 2017, we've actually looked at those indicators and seen some gone up, some gone down. So we actually are seeing changes. Whether those changes are as a result of the collaborations, I think that'd be too early to say, however. Good question, though, Sean, and hopefully we will have evidence down the line that we can associate with the collaborations that are now occurring.
Chris, I don't see any other questions in the box right now, so maybe you could spend a couple minutes telling us about what you saw in the plans that were submitted and what's the how much collaboration between hospitals and health departments there really is evidence of new collaboration given the requirement in 2012.
Well, when we compare those answers with the last time we looked at it, which was in 2010 and 2011, I think we're encouraged that more and more hospital local health department collaborations are occurring. One of the things, Ann, that we all need to realize is that there's a considerable amount of change right now going on in the healthcare delivery system with regard to hospitals. Hospitals are closing, they're combining. We have systems in place now that we didn't have even 5 years ago. So we may actually be working with new partners within the hospital world than we started with in 2008, and we're seeing that. But we actually have lost some hospitals too, and you know, Dr. Crescetti might be able to comment from his perspective because there's multiple hospitals in Albany County. How are you finding this this working out, Dr. Crescetti? Are you finding that they're more eager to work with you, or are they resistant?
Well, it's funny, it's changed over the years. When I first started, a long time ago, did my first community health assessment, local health departments really had all of the data. So we have 3 hospitals in Albany County, and one hospital that happened to be a Catholic hospital and had a unique mission to serve the community was first to contact the health department to ask for data as they developed their community service plan, and that established a good health department hospital connection that led to a joint community health assessment being developed. So this is the late 1990s. Since that time, data has become more readily available to hospitals and community partners that wanted to write grants, and the state health departments done a terrific job being the repository of a lot of community health data, but it took the local health department kind of out of the loop when it came to being a valuable resource when it came to community health data. Now, if we go forward in time, there have been different incentives that hospitals have had to connect with local health departments. We have one hospital that is a very large teaching hospital with a medical school and large specialty practices that is really a regional medical center and doesn't look at itself as a community hospital. So their commitment to doing a community service plan or a joint community health assessment is a bit different from the other two hospitals we have in our community that are more local, more community oriented. Chris is right. As you look at some of the factors that influence hospitals these days with in New York State, a major change underway with a Medicaid waiver that is designed to reduce hospital admissions by 25% over 5 years. And right now we're in the midst of looking at partnerships that will help us to really transform the delivery system, primarily affecting Medicaid patients in New York State. And so this is aligning hospitals and health departments and a variety of community stakeholders to look at ways to establish a performing provider system that will enable us to achieve the triple aim, that is, improve population health, reduce hospital costs, and improve patient satisfaction. So this is one of those external motivators that brings hospitals and local health departments to the table. And I'm commenting from a local health official in upstate New York. In downstate, in the metropolitan New York City region, there are hospitals that could be closing, public hospitals, large safety net hospitals that will be using some of this Medicaid waiver funding a bit differently. But I think this is what Chris is referring to. There are these external pressures that are influencing the collaborations among community stakeholders, primarily hospitals and local health departments, as we look to achieve collaborations that can help to promote the health of New Yorkers in the future. Chris, did that answer your question?
Yeah, it sure does. And one other example that we've seen in the reports that we've been getting from hospitals is that they often collaborate with one another on the prevention agenda. So you may have 3 hospitals or more all agreeing to focus on the same priorities and working together to address them in a collaborative manner. So it's not simply a collaboration between public health and hospitals, but here you have a collaboration between hospitals, which is a noteworthy gain, perhaps, from where it's been in the past.
That's great, Chris. Does anyone else have any questions for the speakers? Okay, well, we'll give people a moment to think. I think, Chris, I was wondering if you had any questions for the audience. I know you mentioned a couple of times that there was a lack of literature on different aspects of the project and the thinking that you did initially. There may be some other researchers on the phone who are doing similar projects or have some ideas about collaboration or sharing information. So in this work, I know a lot of people are thinking about projects in this area if they haven't already started, and what are some of the information needs that you would see going forward?
Well, I mentioned the key informant interview phase of the work that I did, and I did that first because I wanted to get a sense of what was happening across the country, and there clearly are states that are out in the lead. It's not just New York. I mean, New York has taken I feel a bold step at developing a statewide policy, but California, which often marches in lockstep with New York, not always in the same way, but it's surprising how often New York and California are bellwethers of change. There you saw some significant investments in population health and collaboration between the health departments and the hospitals. Same in North Carolina. The Frontiers publication that University of Kentucky and the Robert Wood Johnson Foundation and so forth have supported has published an article on work that's going on in Washington and Oregon. So we're starting to actually see some examples, and I would encourage, if any of you are out there doing this kind of work, to develop case reports or brief articles for Frontiers so we can begin to see what's happening in your neck of the woods. Frankly, it's, what I was able to discern is perhaps just the tip of the iceberg. I mean, does anybody on the call have any particular suggestions of things that they either know about or would like to see us do here in New York?
Chris, this is Paul Irwin, University of Tennessee. Very nice work that you've presented just now. Just one sort of question slash suggestion, and you've probably already looked at this literature, but I wonder if there are any parallels in the current status of the exploration of the integration of public health and primary care. And whether or not there might be something to be gained from work in that arena.
Well, that's certainly been, that was an Institute of Medicine topic a while back, and there's certainly a tremendous amount of momentum going in that, and I do believe there are other awardees within the foundation that are actually looking at that. Eric Carlton, for example,
right.
In Tennessee, who was one of my early sort of mentors on this project. Eric and I talked a lot about both of our projects in the early phase. So I think you're absolutely right, Paul, that the two themes probably have more overlap than not, and it would be wise to look at those. So, for example, Eric sent me his entire literature review database. As a resource for the work that I'm doing. And I've also shared with him the articles and the journals that I used.
Well, you're a step ahead as usual, Chris.
Well, I'll tell you, Paul, this is not an easy literature review.
No, I can imagine.
As Cynthia Lambert can attest, I didn't get it done as quickly as I would have hoped or she would have hoped. I did get it done, and I'm still working on it, frankly. The area that I still need to do a fair amount more work on is the area of sustainability. And I mentioned that, this is a relatively new area, and Ross has generously provided me with a number of suggestions and actual articles in the field, but perhaps this is another area where much more can be learned and looked at.
Yeah, and just one final suggestion. But you mentioned the work of Stephen Fawcett, and their work in Kansas has really focused on evidence for sustainability and of community partnerships in general, not just hospitals. So there may be some potential there.
Just on that note, Paul, two authors really emerged to me as being important. One was Marshall Kruder, who's formerly been at CDC. Marshall has written some very nice work on evaluating partnerships. Fran Butterfoss has written tremendously on this topic.
Right.
I think partnerships can learn a lot from Dr. Butterfoss's work in managing their own partnerships, frankly. So that's a very practical guide that partnerships may want to consult as they keep their efforts going.
Right.
Okay, do we have any other questions for the panel? Hearing none, we'll just Chris, thank you so much. It's been a great overview of where your project is and where it's going. And do you have any final thoughts about the time frame for when we might have the results?
Well, I think Ross laid down the the rule there. I want to get it done in this millennium, so that's what I'm working for. I'm in high gear right now. I want to get this done.
Okay, well, that's encouraging. So maybe by the end of the year, early next year, we'll be able to find something. Certainly next year's Keeneland conference.
Keeneland 2015. There you go.
Got it. Got it.
Well, I would just like to say, if I could, Ann, thank you and your team at the University of Kentucky. Thank all the people at the Robert Wood Johnson Foundation for providing me the seed funding to get going on this. I was able to stretch those dollars very far by getting a lot of gratis work from my fellow public health students, believe me, several of which have continued to want to work with me on the NACHO data particularly. So I really want to thank the Foundation and the University of Kentucky for getting me this far.
Well, that's great, and you're very welcome. And Chris's information is here on the screen, and it's also in the slides that are available upper right-hand corner if you want to get in touch in the future. Thank you, and to Dr. Brownson, Dr. Crissetti. Just quickly, I wanted to review our upcoming, as I said, Chris is the first of 10 presentations in the series. The next one is scheduled for mid-June. Teresa Green, who's also from the New York State, the University of Rochester Medical Center, will be presenting on her topic, also a doctoral dissertation, quantifying the value of public health intervention. Then we're taking July off, and in August we have two, one on healthcare reform and colorectal cancer screening and its effect on expanding it to reduce disparities. At the end of August, the cost-effectiveness analysis of a fungal meningitis outbreak and the costs associated with investigating that outbreak. In September, improving partner services in New York State, performance management approach. At the end of September, State Health Department foodborne disease outbreak reporting. Santa Pyridythyl completed this in working with Jennifer Ibrahim at Temple. So it's a very interesting policy-oriented presentation. Simone Singh presented some of this work at the Keeneland Conference. Some of you may have seen it, Variations in the Cost of Delivering Public Health Services, Analyzing Local Health Departments in Florida, which is, again, very instructive. And then the last couple months of the year, we have a relationship, again, in Tennessee, Public Health Workforce Competency, Provision of Services, and Health Outcomes. November 12 is a workforce analysis by Angela Beck on trends and characteristics of state and local public health workforce, a national perspective. And then we're wrapping up with Eric Carlton's presentation, which also looks at partnerships between public health and healthcare in Memphis, the county where Memphis is located, and commentary by Dr. Paul Irwin, who is on the call today. So that's our series for the rest of the year. We'll also be expanding the series in the next year to other grantees that have been recipients of larger awards, so look forward to the announcement. So with that, do we have any other questions for today? We are recording this call. It will be available on our website, and we'll be sending out announcements. So thanks everyone for participating today, and we'll adjourn 2 minutes before 1. So thanks a lot.